deliciosos, I have to make an addition to that. This will be my only Spanish slide. Don't be too disappointed. The rest of the presentation will be, of course, in English because my Spanish is almost zero. So I will speak about general principles in the treatment of micosis fungoides and sezary syndrome. And for this purpose, I would like to take you back to the original description of this disease, because history, I guess, is always important if we want to understand what we are doing to our patients, what we are diagnosing, and how we treat our patients. And on the left side of the slide, you see here a person, Jean-Louis Alibert, he lived in Napoleon's times, or probably, as you would say, in the times of Simon Bolivar. And probably he even looks a little bit like Simon Bolivar. And he was at the origin of dermatology at the turn of the 18th to the 19th century, quite unsafe times, you would say. And what he did is he wrote one of the first textbooks of dermatology, highly illustrated with beautiful images. And one of these images is a man named Lucas. We even know his first name still. And Lucas had this disease, which Alibert called micosis fungoides, or pion fungoide, as he called it in his French textbook at that time. This was the original of the term. Also, Alibert knew nothing about the nosology, about how to categorize this disease. But anyway, the name sticks until today, and is still there. Sezary syndrome, on the right side of this slide, is much younger. Albert Sezary, it is funny, is one of the successors of Alibert. Alibert was at the hospital St. Louis, and Sezary also was chairman of dermatology at the hospital St. Louis, and he found, described for the first time, a disease that you all know that consists of erythroderma and these strange large lymphocytes that he described in his patients, cellules monstreuses, monster cells, as he called it. At that time, you also could not tell how to categorize this disease, how this might relate to micosis fungoides of Alibert. And to make this long story short, it needed quite a time, another few decades, until we have a system now of lymphoma classification that has proven to be clinically useful. And many of you, at least the oldest, the older colleagues in the room, have had probably a lot of troubles in the medical study to learn those more or less useful classifications we had before. But since 2005, and this is due to the menus in the slide here, I visited from the Netherlands, we have a clinically useful classification. And you see in yellow here the two conditions that I will be talking about, namely micosis fungoides, which we now define as a cutaneous T-cell lymphoma, to be more detailed, the most common variant of cutaneous T-cell lymphoma, which has approximately a frequency of 44%. So 44% of all primary cutaneous lymphomas are micosis fungoides. Micosis fungoides, and you can also find this data in this publication of 2005, has, as we all know, an excellent prognosis. So the 5-year survival rate is about 90%. Sezary syndrome, in contrast to that, is an exceedingly rare disease. And many of you probably have never seen a patient, but most of you probably in their lifetime, if they're dermatologists, will see at least one or two patients. So this is a very rare disease that needs a specialized center for treatment. The frequency, as is on the slide, is low, so 3% of all cutaneous lymphomas are Sezary syndrome. But this is an aggressive condition in contrast to micosis fungoides. The 5-year survival rate is only 25%, so this is a severe disease. I will not go into detail about the other conditions in this classification. You can look this up in this landmark paper of 2005, which is still valid. But as you all know, you probably will see in the subsequent lecture clinical examples. I will not show too much of those clinical examples. Micosis fungoides can have a large variety of clinical presentations, from early stage diseases, and severe with limited plaques, up to tumor disease, and various other variations like follicular micosis fungoides, hyperpigmented micosis, and so on and so on. There are numerous flags, and you probably have all heard about these areas. I will not go into detail here. But we know there's a broad clinical variation, and this important that you categorize the patient with micosis fungoides correctly. There is a staging system that has been published in 2007 by Olsen, which should be used for staging of those patients, because as you see here, clinical stage is not irrelevant. The prognosis, as I said, of a stage 1A patient, this is the limited blood stage, is excellent. In fact, it does not differ too much from the average population. But as soon as the patient has generalized blood, prognosis drops significantly. And this goes on when the patient has tumors, and the patient with sezary syndrome, in fact, has the same prognosis, the same worse prognosis, the same bad prognosis as a patient with micosis fungoides and organ involvement. You see, it's important that we categorize patients correctly, because treatment, and now I come to treatment, is mainly based on clinical stage. It's important that the correct clinical stage to decide on treatment. And you can imagine, and many of you, if you care for those patients, know this, of course, that you will treat a patient with this early disease that you might call psoriasis. That you need to treat such a patient completely different from patients with this advanced stage of disease. Also, it's the same condition. It's still micosis fungoides. And since this is a little bit difficult and sometimes confusing, there are a number of guidelines and recommendations that have been published, and I only show you a few of the most, at least to my consideration, the most important of this. An excellent paper has been published in 2003 by the British Association of Dermatologists, and is, as far as I know, currently under updates. You can expect in the next year or the year after that an update of the PAD recommendations for micosis fungoides and sezary syndrome. This proved to be excellent, and I expect that the subsequent paper will have the same quality. There's another publication I will draw your attention to, and the Cochrane review. We even have now a Cochrane report about interventions for micosis fungoides, but I'm not sure whether you want to read this because it's rather disappointing. The main message of this Cochrane review, as with other Cochrane reports, is that simply the evidence levels that we have are too low to draw definitive conclusions. And this is the reason why the European Association for Research and Treatment of Cancer, which has the lymphoma group, published a paper which they didn't call guidelines, but consensus recommendations, because the evidence levels in these publications, which I had the duty, I would say, to write together, is that evidence levels are too low to make guidelines. So we stepped back one step and said we are going to make a consensus. Another important publication, which is quite recently, is clinically quite useful because it provides very helpful practical algorithms to decide which patient gets what treatment. The newly devised NCCN clinical practice guidelines in oncology. A chapter devoted to micosis fungoides and sezary syndrome, and this is highly recommended. We are currently updating our consensus recommendations, and I hope that next year you will see this in print. And what I tell you now about treatment is mostly what we're currently discussing about for this update. Now, as different as the recommendations in these various papers might be, there is one consensus in all guidelines that has been published so far, namely that if a patient presents with early stages of the disease, you should start with skin-directed therapies. And there are a number of these skin-directed therapies. You have probably complete list of the skin-directed therapies here on this slide. It starts with topical corticosteroids, the favorite treatment, favorite skin-directed treatment of dermatologists all over the world. Phototherapy is critically bold because this lecture I give here is was originally devoted for the phototherapy or photodermatology symposium yesterday. And for the rest of the presentation, I will mainly focus for this reason on phototherapy. We have, in addition to that, radiotherapy, which is very useful for localized disease, and at the same time as total skin electropine for generalized disease. I don't know whether you have in America Latina topical chemotherapy with mecloretamine. In the United States it's very common. In Europe it's rarely used. You don't have it. No. We don't have it either, so I cannot tell you too much about that. But in the United States it's very common because it's cheap. We don't have backdoor gel in Europe. I don't know whether you have that. Do you have backdoor gel? No. In the United States, it's available for topical treatment and retinoid, but we don't have it either. And there are various other experimental treatments that we could use. But starting out with phototherapy, we again go back to the origins of phototherapy for micosis fungoides. As the treatment has been introduced by those two people, quite famous dermatologists and photodermatologists, you might know those people, Barbara Gilchrist and Tom Fitzpatrick, both from Harvard here. And Tom Fitzpatrick devised tuber therapy in 1974, if I'm correct. And it needed only 2 years until they used this treatment also for micosis fungoides. And Barbara Gilchrist published the first paper on the treatment of micosis fungoides with photochemotherapy, as Fitzpatrick called it. And here you see one of those typical patients. And at that time, dermatologists were very enthusiastic about cure in micosis fungoides because before that it was not possible to achieve such a complete response in micosis fungoides with any other treatment. So this was really a milestone or breakthrough in the treatment of micosis fungoides. And Barbara Gilchrist could achieve 100% response rate in her 9 patients and complete response in almost the half of them. And what she did additionally to treating those patients, she also found out that, or showed nicely in her experiments that tuber therapy, at least in the treatment of micosis fungoides, has only a local and no systemic effect. What she did in a few patients, she shielded 1 hour and treated the patient with tuber to show that only the treated areas will respond, the shielded arm will not respond. So she showed at that time what was not known before, that photochemotherapy has no systemic effect, but is in fact a topical treatment. Now we have, of course, more than 30 years have passed, and we have a lot of studies on photochemotherapy in micosis fungoides, but in this area, it's the same with other areas in photodermatology. Evidence levels eventually are low because study protocols and treatment protocols differ widely. But in general, we have such a high number of patients that we now can confidently say that this is a good treatment for early stage micosis fungoides. And if you do it correctly, almost every patient with early stage disease will respond to it. In stage 1A, you can achieve complete remissions in almost 100%. And the more the stages increase, the more the response rate will decrease. That's firm knowledge, we would say. Also, big control studies are lacking, but as you see, the cumulative number of patients, the cumulative evidence is so high that this has become a standard treatment for micosis fungoides. Now, if you are a milestones in the phototherapy of micosis fungoides, the next milestone was the introduction of UVB. UVB was introduced in the United States by Wilson. This is broadband UVB, and I will not go into detail about broadband UVB, and you will probably understand in a few minutes why. Another milestone was the introduction of extracorporeal photochemotherapy or photopheresis for the treatment of erythrodermic micosis fungoides or sezary syndrome. And I also will not go into detail here because my friend Robert Knober has gave a lecture on this. And another lecture was given by Dr. Enz from Argentina yesterday. So I will skip extracorporeal photopheresis for the purpose of this talk. Also, it's one of the main treatments for, or it has become one of the main treatments of the first line options for sezary syndrome. But a milestone that is important because it has changed again phototherapy of micosis fungoides was the introduction of narrowband UVB lamps in 1988 by Van Weyden and co-workers. And the mastermind behind this invention was the photobiologist Van der Laan from the Netherlands. And they developed the lamp specifically for the treatment of psoriasis. They targeted, they tailored the fluorescence bulbs to emit almost exclusively irradiation in the area of 311, 312 nanometers to maximize the effect of UVB therapy for the treatment of psoriasis. And interestingly, it needed 11 years until the first publication appeared about the treatment of micosis fungoides. So remember, with tuberous was only 2 years, but with narrowband UVB it lasted for a reason. I cannot understand that after 11 years, until a group from Austria published the first